Today, do join us. Today, I'm really excited because today we are going to hear from Danae Bear. And actually pronounce your last name for me because I know there are so many different pronunciations across Louisiana. It's Bear?
Yes.
Okay. And she's going to talk to us about telehealth. She is with the Bureau of Primary Care and Rural Health, and I'm sure she can tell us a little bit more about how she's oriented within everything. And her title is Healthcare Innovation Manager for Well Ahead, which is the Chronic Disease Prevention and Healthcare Access Initiative. And before that, she worked for 6 years in hospital corporate compliance, specializing in hospital licensure and certification and the promoting interoperability program, which was formerly known as Meaningful Use EHR Incentive Program. I love medical job descriptions because they all sound so compelling, our job titles. And so really happy today because as part of our conversations with HRSA, AHEC Scholars is part of a HRSA grant, it's HRSA funded, and HRSA is the Health Resource Services Administration. And we were talking with Well Ahead and the Bureau of Primary Care and Rural Health about doing a COVID-oriented grant, and they also do a ton of telehealth stuff. And so I asked Danae to please come and talk to us about, which asked her if she would be interested in it at all. And she was far more excited about it than I thought she would be. And so I'm gonna go ahead and hand it right over to Danae now. And so let's all welcome her. Thank you so much for being here.
Yeah, of course. I was very excited when Robin reached out to me. Because this is going to be a very different presentation than I normally get to do. I spend a lot of time giving the same kind of telemedicine 101 presentation and like listening to the same type of presentations over and over again. And then with COVID, all I talked about was COVID and changes and CMS and all of these things for months and months. And so I'm very excited to talk about not that and to lead a little bit of a different type of education. So I do have just slides to do. Can y'all? I think y'all should be able to see. There we go. So like you mentioned, I'm with Well Ahead Louisiana, which is in the Louisiana Department of Health under the Office of Public Health, and we are partnered with the Texas Telehealth Resource Center, which is a HRSA-funded entity that provides technical assistance to new and existing telehealth programs in Texas and Louisiana. So through the partnership, I also serve as the site coordinator for Louisiana. So those are automatically going. So what that means is that if there's a provider in the state who has questions about telehealth, or anyone really who has questions about telehealth in Louisiana, I would be the primary contact to provide that support. So, so me being here is kind of part of that relationship as well. So here's kind of the agenda. We'll do some introductions because I do want to know who you are and your background and where you're from and those sorts of things. And then we will, I'll open it up for questions and clarifications around all the readings and things that I just send out ahead of time, get some, answer some questions you might have about like baseline knowledge around telehealth. And then I really want the bulk of this meeting to kind of hear from you guys, and I'm excited to hear from you. I have some kind of poignant questions around cost and quality and health access and equity related to telehealth. And those are the topics selected from the survey. Oh, okay. Can y'all still hear me?
Yes.
Yes.
Okay, sorry, I got kicked out of the Zoom, but oh, here I'm back. So those were the topics that were ranked highest for the group discussion in the survey. So thank you for completing that. And then also from the survey, thank you again for taking that because it really let me know that there wasn't one particular thing about telehealth that you needed to know. It was kind of everything. And so I didn't want to send a bunch of resources of things that you already knew about. So I was glad to know kind of what the need was there. And then, so we'll have the discussion around those questions, and then we'll wrap up, and then we'll have some time for final questions and comments. So for the introduction, if we could go around and probably for simplicity, I am kind of getting kicked in and out of Zoom, so I'm not going to be able to call on people because I can't see your name. But Robin may be able to assist me in going down a list. But I would like to kind of, what's your name, where are you originally from, and where have you lived? And that kind of helps me put into context your experience. Have you lived in rural areas? Have you lived in urban areas? Only in rural, only in urban, or in both, that sort of thing. And then what's your area of study or practice? So I know there were some people, public health. I think we have a physician, a nurse. If I remember, maybe an audiologist. We have a wide range of specialties, so I'd kind of like to know what your specialty is. And then if you know what the focus of your project is, what that is as well. And then just, have you or a close friend or a family member ever used telehealth? Do you have any personal experience with it? Just to kind of get some context. And if you can, at least when you're introducing, turn your camera on so I can see your face. And hopefully my Zoom will last so that I can see you.
Okay, so I'll call on folks, and so I'll go in reverse alphabetical order. So Val Rabin is first. I'll go ahead and unmute you, and you can use your video if you want. No, I can't unmute you because I'm not the host. She is. You have to unmute yourself. Good.
Okay, hi, can you hear me?
Yes.
Okay, so I'm Val. What was it that you wanted? I'm sorry. Okay, I'm originally from suburb of Chicago. I live in
on the screen. You don't have to.
Okay, okay, yeah, so I live in New Orleans now. I study audiology. The focus of my hex. So our focus is, well, my groups is how kidney disease and hearing loss are related for Black people in New Orleans, and then specifically, I don't know. Sorry, we're just gonna go with that. Okay, and then do I have any close friend or family members use telehealth? I've used telehealth. I don't know about any of my family. I know my grandpa uses it for his hearing aids, but yeah. Okay.
Thank you, Val. All right. So the next person is Tassin.
Just a second. Let me see. Okay. Can you guys hear me?
Yes.
Okay. Hi. My name is Tassin Kareem. I am originally from Bangladesh, but I've lived in Lafayette, Louisiana since the age of 13, and then moved around here and there for a bit. My practice or area of study is I'm majoring in epi for an MPH. I'm going into my second year currently. And my focus for AHEX College project is looking at the difference of folate levels and other important nutrients in like different minority groups, and also different, like depending on different socioeconomic status or different groups, and just seeing what the prevalence would be. And I do not have any friends or family members who have used telehealth yet. I was actually talking to my dad the other day, and I think he had an appointment with the doctor, but I think he just kind of got scared. And because, not scared, but he's not used to the telehealth because that's what they're doing. He just postponed it. So that would have been like a first time for a family member to use telehealth, but it didn't happen yet. So.
Thank you, Tessie. Chikara.
Hello. So I'm Shakara Hamilton. Where am I from? I'm from Mississippi. I lived on a farm for a little bit until I was like 8-ish, give or take. And then I moved to the city, but all of it's in Meridian, Mississippi. Area of study. I am currently a 4th year in my doctoral program for clinical psychology. The focus of my AHEC Scholars Program was going to be a nutrition project, but since COVID hit, that's going to get tweaked. But by August 1st, I will have another project. And I have been using telehealth as a student therapist for about 4 months now.
Cool. Thank you so much. All right, Nora.
Hi, I'm Nora Maria Fuller. I grew up in Connecticut. It was a rural area, and I moved to New Orleans in 2007. So I've been in the city, and I am studying medicine. And the focus of my project is syringe access. I've written about a particular neighborhood in New Orleans, but I'm also really interested in delivering services via telehealth to folks in rural places. And I just had my first telemedicine visit with my physician, and it came kind of well in school. We were kind of doing like pretend patients on telemedicine, and that was the extent of my personal experience with it.
Okay. All right. Thank you very much, Miss Fuller. Miss Abedy.
Can you hear me?
Yes.
Okay, my name is Mahsa. I'm studying audiology as well. I'm from Iran, and I was living in Houston, Texas before coming here to study. And same as Val and Jensen, we are working on kidney disease and the importance of audiological assessment in these patients to see if like patients with this disease have access to like audiologist like evaluation, and I think that's it.
Do you did you say the thing about the telehealth part?
Oh, I did have experience like with telehealth. I had cold and I called my doctor. So because of the current situation, we visited over the phone. It was really like effective, and I really liked it. That was my experience.
All right. Thank you so much. Katie.
Okay. Hey, I'm Katie. So I grew up in Wisconsin, but I moved here in 2014. That's the only 2 places I've lived. I'm a 3rd year dental student, and my project is focusing on Medicaid policies that support dental care in like a primary care setting, specifically for children with disabilities. And I don't have any experience actually with telehealth.
All right. Thank you, Katie. Jansen.
Alrighty, so my name is Jansen. I'm from New Iberia, Louisiana, which is by Lafayette. I am a 4th year audiology student, so I'm with Masa and Val, and we are doing the whole kidney disease and hearing loss and how an audiologist can play a role in that. So as audiologists, we do perform telehealth. Personally, I have not participated in it, but I've seen supervisors, do it or talk about it, and we've talked about it in class too.
Thank you. All right. Harmony.
Hey y'all, I'm Harmony. I'm from Sugar Land, Texas. It's a suburb outside of Houston, and lived there my whole life. Now in New Orleans, been in New Orleans for the past 5 years. For working on toward my second year toward my MPH in nutrition. Similar to Shakara, I was gonna do a nutrition-focused project, but since COVID, a lot of things are aligning to look more deeply into homelessness. So I think I'll be focusing on that for my AHEC Scholars Project. And I haven't had any experience with telemedicine, but I'm eager to learn more.
Well, I'm happy to hear that, Harmony. Thank you about your project. That's exciting. Let's see. Desiree.
Hi, I'm Desiree. I am from Fort Lauderdale, Florida, but kind of bounced around between there, Miami, and Jacksonville. I'm also doing my MPH, but in maternal and child health. My project with Arden will most likely be on actually with telehealth and how that has affected home visits. And I have not had experience with telehealth, nor do I know if any family members have had experience with it.
I like that you're wearing your Florida hoodie for the
It's kind of cold in my room, so
yeah.
I don't have any tooling gear, unfortunately. So
It's better than if you were like wearing your Texas hoodie and you were like, I'm from Florida. The brand is solid. Thank you. Let's see. Did I not? Oh, and then Arden.
Hi, my name is Arden. I'm originally from Lafayette, and then I moved to New Orleans for my undergrad, and so that's the two places that I've been. And right now, I'm about to enter my second year studying medicine. So I'm working with Desiree for my project, and we're going to be looking at maternal child health, and we're going to be looking at kind of like she said, telehealth and how it's like impacting home visits, and kind of learning about it from the perspective of the providers, which will be interesting. And kind of like Nora, we did some like practice telehealth sessions. I'm kind of hesitant to call them that, but we kind of played around with the idea of telehealth in school this last semester. But other than that, I don't really have any personal experience with it. So.
Thank you, Arden. All right. And Kelsey, have you had a second to get situated and see what's going on? You're ready to share? I see she's got a video. There you go.
My name is Kelsey. I'm originally from the Seattle area, and then my undergrad was in San Francisco. And then I moved to New Orleans after that, so I've been here for a little bit, and I'm studying clinical mental health counseling at Loyola. Focus of my project. It's been on hold for a minute. I think probably like a lot of people. I had wanted to work with people experiencing homelessness, but I haven't quite figured out how that's going to look. I've with COVID, I haven't really been interacting with anybody, so taking a pause on that for a minute. I've used telehealth as a client for counseling as well as like medicine, but I've never practiced it. But I've heard a lot from classmates who are in their practicum right now about what that is like for them.
Thank you, Kelsey. And maybe you and Harmony should have a little convo sometime soon. I will make a note and maybe facilitate. Okay, so I don't think you need me anymore, do you? I think you good?
I think we're good. I think we taught everyone. I'll go through and I'll do mine. So obviously my name is Janae Aber. I actually grew up in Branch, Louisiana, which some of you, like I heard some people from Lafayette, New Iberia, you might be kind of familiar with that, but it's very, very rural. It's actually not considered like within any city limits. It's in the parish. It's unincorporated, all of those things. It lives in a field. So grew up very, very rural. And it's kind of located, if you're familiar with Louisiana geography, between two small towns named Grain and Church Point. And if that's too small for you still, it's close to Lafayette. So to kind of give you some context, now I live in the Lafayette area. When I was in school, I was in Natchitoches for a little while, and I was in Jackson, Mississippi. And then I actually, after college, lived for about 9 months in a very small town in the north of Spain, which is a very interesting experience. And it was a very different lifestyle. But I've never lived in a big urban area. Most of my living experience has been rural, and Jackson, Mississippi was probably the biggest city I've ever lived in. She gave you a little bit of my background. My professional experience is mostly around like compliance and regulatory, that sort of thing. I have my MBA with a focus in healthcare administration, and then I have a certification in healthcare compliance, and I work with the state now in the Office of Public Health. Obviously, I don't have a scholars project. I actually do not have any personal experience with telehealth, which is kind of funny because I work on it all day, every day. But I do have family members who are attempting to use it, who are very happy to tell me all the good and bad experiences they have with telehealth. So I hear it from all sides. So I sent out a lot of readings, I know, and I hope it wasn't overwhelming, but Robin told me that you guys like reading, so I took her word on that. And there were a couple that were listed as kind of required, just to give you at least a foundational knowledge of what telehealth is, what the definitions are, which if you looked at that document, everyone defines it a little bit differently, but you can kind of get an idea of what we mean when we say telehealth versus telemedicine, what the different types are. And then there was that 101 presentation that kind of gave a high level overview. And that's actually one of like a recent text law presentation that included some basic information and then some additional COVID changes and things like that. So I figured that'd be a good one to send you if this is what, this is the information that's actually given to providers who are trying to start a telemedicine program. So that's kind of some base information. So I wanted to start with opening the floor and are there any questions? Was there something that from those kind of required readings, and there were some additional links and attachments that were more detailed information. If anything in the presentation was unclear or you wanted more information, there was a lot of other references there. So was there anything that you didn't understand or wasn't clear from those things that were sent out? Anything you wanted additional information about? Or any other additional foundational information that wasn't included, wasn't provided, that you feel like you need before we go into any kind of discussion around telehealth and cost, quality, and equity and access?
This is Nora. I had some confusion. I think it was the American Hospitals thing. There was a point where they talked about how the budget office had estimated that because telehealth or telemedicine would increase access to care for more people, that it would have a cost of like $150 million a year. And then in reality, it was like $48 million over 8 years, something really silly like that. But what I have a question about is this idea of policymakers not wanting to increase access to healthcare. Like there is a point being made with that government office saying like, this makes it too easy and more people will access care. And I wanted to know like the background of that kind of policy point.
Yeah, so I don't know if I know the exact background, but that is and that's actually when we get to the access question, that is kind of something that I think will come up of if you make it too easy for a patient to have access to care, especially if you're reimbursing a telehealth visit at the same rate as an in-person visit. Well, if it's really easy, are they going to overutilize in the way that, there's a lot of talk about overutilization of the emergency department, for example. And so if you make it very easy for the patient to do it, are they going to overutilize and utilize telehealth for things that they don't really need to see a doctor for at all? And then you're paying the physician for care that's not medically necessary. So I think that, I don't know if that answers your question, but I think that's kind of the argument about too much access. I see we had somebody just jump on.
So sorry about that. I completely forgot about this, but still wanted to hear about it. So sorry.
Not a problem. Can you just very quickly, just because I'd like to know who everybody is, can you just give me a brief description of who you are, where you're from, what your area of study is, your AHEC project, and any experience you have with telehealth? And I'm actually going to move this slide back to help you remember all those questions. You're muted.
Oh, I'm Haley. I'm from Mandeville, Louisiana, and I'm in dental school right now. I just started my 3rd year, and I've never heard of telehealth before. I mean, I've been hearing about it now, but not in the past or anything. And my focus of my AHEC Scholars project is dental insurance, and basically, is it a scam for people? Not a scam, but just not worth it to have. Yeah.
Gotcha. Well, glad to have you. So where we are now is I had sent out some readings and stuff, and so just if there's any questions about any kind of the technical stuff around telehealth, because when we move into the discussion portion, it's going to be more focused on real life application of telehealth and how it really impacts what we're doing in the real world. And so just I just wanted to give the opportunity in case anybody had any questions about some of the more of that foundational knowledge about what telehealth is and that sort of thing. So I'll just wait just a couple more seconds to give anybody a chance to ask any questions they might have, and then we'll move on into the discussion portion. All right. So like I said, my main goal of this session is to facilitate and support you guys having a real discussion, because I'm actually very excited. You guys have a very diverse background, both in where you're from and where you live and your experiences, both in professionally in your area of study, and then your experience with telehealth, personal or family, or none at all, or don't even know what it is. And so, again, selfishly, I talk about telemedicine all day, every day. So I'm really excited to hear from other people what you think and how you view this, being applicable in the real world. And so I want to really challenge you to think critically about telehealth and technology and what's its place in healthcare. And so, and we'll focus around, like I said, cost, quality, access, and equity today. The questions will be really specific to that, but I'm hoping that it kind of sparks in you the thought process of, as you move out into, into your projects and then into, your workplaces and the things you do in the future, that you'll be able to really think critically about technology. Oh, was I gone for a minute? Or did someone come in?
Because you're using your phone, your voice stays steady.
Okay, good. All right, because I heard a ding, so I was worried that I got kicked off the audio. So yeah, so there are people who don't want to have anything to do with technology and healthcare, and there are people who think it's the greatest thing and it's the solution to everything. And then obviously there's thoughts all along the spectrum of that. So the goal is to really think critically about these issues. So we'll just set some ground rules. So again, I want everyone to speak. When you do speak, speak respectfully with positive collaborative intent. Allow and encourage everyone to speak. We all have different knowledge, experience, and expertise. Listen actively and respectfully and assume positive intent of the speaker. And then there are no wrong answers. But, we all, speaking for myself, know that none of us can speak on behalf of any other person or even on any entire group of people. Even if you belong to that group of people, I am a woman, but I cannot speak on behalf of all women, right? And so sometimes we do have a tendency to kind of fall into that, not purposefully and not with any malintent, but try to speak from your personal perspective, your experiences, your observations, or with the support of verifiable information data that you have seen and have access to. So we're not generalizing anyone or anything in a negative way. So based on the readings and your experience and observations and all of those things, the first question is, in what ways do you think telemedicine can decrease costs both for patients and for providers?
For patients, they don't have to drive into sessions, and if they live far away, I used to have clients that would drive 2 or 3 hours for an evaluation, then they have to get a hotel, and they have to get food, and they have to get gas. But with telehealth, there's an option to, or telemedicine, whatever you want to call it, to do it just over the phone.
Mm-hmm.
I think the same thing is true for like the physician. For sure, less staff are needed, I think, and also they can work from home as well, so they may not need to like travel.
Mm-hmm.
I think for the patient as well, they may not have to take off of work to accommodate like their traveling time to get there. They may be able to do it over like a lunch break or something. So maybe like decreasing, like losing a day's work of pay or something like that.
Yeah, and it sounds like a lot of you guys are working with populations that a day off of work, even a few hours off of work, may be a huge deal, right? If you're working an hourly job, taking an afternoon off can impact your paycheck, and that can be a huge deal. Any other thoughts on decreasing costs?
For providers, I think you can have like fewer exam rooms and the equipment's really expensive. So you can save costs with, rent and equipment.
And providers are probably also able to see a larger volume of patients as well.
I think also for geriatric patients or patients with special needs, they don't need to have like caregiver or someone to be with them during the appointment.
Mm-hmm. Yeah, those are all great insights. So are there ways that telemedicine might increase costs for either the patients or the providers?
I remember reading that not all insurances cover telemedicine. So for some patients, that could be a big increase in cost.
Mm-hmm.
You might have to upgrade your internet. I don't know, it's called speed or quality if you're trying to do telehealth.
Also, sometimes smartphones are needed like this is the case for hearing aids. We were talking to a patient. They didn't have like a smartphone, but if they had, they could use like the telehealth.
Could a misdiagnosis also be like time wasted? So time, you might lose out on time.
I think I also read that there's certain things require like special certifications to be able to be a physician that provides telemedicine or telehealth. So in order for that could also come in the form of getting those extra certifications and credentials that you need. That could be something that could increase costs.
Yeah, Louisiana and several other states have a specific telehealth license. So if you want to practice in Louisiana, but you don't have a brick and mortar in Louisiana, like a building, right, an office, then you have to get an extra license, and that's expensive. And if you're practicing telehealth from a different location, you have to register that location with CMS, which can have extra costs. So yeah, definitely. And then, so thinking about the decrease in cost that we talked about, the potential increase in cost, in what circumstances do the savings outweigh the cost, and in what cases maybe it costs more than it really saves?
I think that situations where it would definitely the cost or the savings would outweigh the cost would be if you have a patient, for example, that the only form of medicine that they'll use is telemedicine, and it's even though maybe in that situation it might not be the most ideal to see them only through telemedicine, it's better than nothing, kind of. So that could be a situation where the savings would outweigh the cost if that's like the only form of medicine that they're really open to using.
Mm-hmm.
I was really struck by this one story from, or a study from an old folks home where they had to invest $30,000 in equipment for Medicare to save hundreds of thousands of dollars in like hospitalization and other costs. So while, it absolutely saved healthcare dollars for the patients and the providers, the nursing home had to spend money for it.
Yeah, and so the savings outweigh the cost on the whole, right? But for Medicare, not for the individual provider, right? So there may be an imbalance there. So we're talking about costs, and I've kind of heard a little bit of you're already kind of leaning into quality, right? And I think as all of us, right, because we work in healthcare and we care about the patients, quality is very, very important. And especially for those clinical people who, your job is to what I call touch the patient, right? I don't touch the patient. I'm over here in the administrative world. But those of you who are face to face with the patient, that's very, very important. And it's top of mind for you all the time. So in what ways can telemedicine improve or increase quality of care or improve patient outcomes?
I think if telemedicine was easier for someone to access, they might, get their diabetes detected earlier. Whereas if they waited until they absolutely had to go to like the emergency room or something, that would be better to get it detected early.
Mm-hmm.
I'm not 100% sure if the time that patients have with their physician, like if it's a little more flexible, but maybe better communication or like feeling more comfortable with the physician if you're able to spend more time with them, but also being in like the comfort of your home might make you feel more likely to open up and say more than you would say if you were like in an office.
Mm-hmm.
So that might help get more back, improve quality.
Sorry, I was looking back. You are a mental health person.
Oh no, I'm public health.
We see that a lot with behavioral health, where patients who would maybe not be willing to go sit in a room and talk to someone, but they'll get on their computer and talk to them. So that is something, especially in the younger population, like teenagers and young adults, that's very common that they are much more comfortable having a mental health, behavioral health visit and talking about, you know, whatever mental health issues they may be facing, substance use disorder, those sorts of things. They're much more comfortable having that conversation via telehealth than they are going into an office.
Mm-hmm.
And then thinking about, so we're kind of focusing a little bit more on that traditional face-to-face, like audio, video, telemedicine, but thinking about other types of telemedicine, like remote patient monitoring, for example. How can remote patient monitoring impact the patient outcome and quality of care?
I was thinking about it, like, for example, like the turnaround in terms of like giving diagnoses and also like kind of like monitoring the patient and being able to kind of talk to them in real time, and rather than, you know, having to schedule another appointment and meet them to talk about their diagnosis or meet them to talk about the readings, but rather just being able to call them and give them those results instantly definitely increases the quality of care, because they're getting those answers and being able to do some of that preventative stuff quicker than if they had to, every time you wanted to talk to them about something, they had to come in person.
Mm-hmm. So are there ways in which telemedicine can lead to lower quality or poorer outcomes? Are there circumstances where that might be the case?
I think just from a dental perspective, like if someone's like second molar way in the back of their mouth is hurting, like maybe if it's a front tooth, they could show it on camera or something and we could, you know, have a better idea. But if it's kind of way back there, it's hard to tell what's really going on.
Yeah, patients aren't always great at, you know, saying what their symptoms really are. So they might say one thing and mean another. And you're like, oh, okay, I think I know what you're saying. And then they say something else and you're like, never mind, I don't know what you're saying. And it's kind of hard, especially if they're like, oh, I have a pain here. And you know how like some doctors are, you know, will press on it and feel it, you know, to kind of help give them an idea of what it may be. I feel like that's just a little kind of like a gray area that's a little difficult to do. So then, you know, patients might get aggravated by saying, well, you said it was this, but you know how patients are.
Technology has been a problem for me personally.
Wait, what? Did someone say something? I'm sorry, I think I cut somebody off.
I was saying that technology has also impacted quality of care. There'll be glitches in connections, or it was difficult at first for us to find the right platform to use at the office. And then if the connection's weak, then we're cutting in and out. And they're going, what did you say? And I have to go, well, what did you say? And it just becomes this whole ordeal.
Can a physician prescribe over telehealth? Can they prescribe medication?
They can prescribe generally medication. There are a lot of limitations around prescribing of controlled substances via telehealth. I don't know currently what has changed specifically with controlled substance prescription in COVID, if there's been a lot of change around that. But generally the rule is that the provider has to see that patient in person at least once a year to be able, and then they can subsequent follow-up visits they can do via telehealth, but they have to see the patient in person once a year in order to be able to do a controlled substance prescription via telehealth.
I think like also like something that can cause lower quality or poor outcomes with telemedicine is like if it's like an initial visit, or if you're like establishing you're establishing a relationship with that doctor or that healthcare provider. It's just harder to do that digitally than like in person, and to like gain that sense of trust and be, you know, comfortable with that person if you're only ever talking to them through a computer screen. It kind of creates a disconnect sometimes.
Mm-hmm.
I think that for the touching professions, like you said earlier, if we miss a sign of oral cancer or something like that, then that definitely leads to a poor outcome whenever we can't find things sooner. And then for like OBGYNs, if you don't get a pap smear every year, or every 3 years, that you're more likely to have cancer. And stuff like cancer testing and just testing in general, I think, is definitely still needed, and it shouldn't be a total replacement of care.
Yeah, so if you do too much telehealth, then the patient never comes in, they never get pap smears, they never get tests, they never get, you know, those screening things that they need, and you're missing diagnoses potentially, right?
I get kind of excited about the idea of increasing the quality of resources that people could use on themselves. Like more education about their bodies, and like more ways of like testing at home. You know, like for example, there's been HIV home tests that the FDA cleared for maybe 5 or 10 years ago, that just like really don't get a lot of use, that now with COVID, there's like a space for utilization, you know, that you can kind of write grants to send people home with the tool that you might have been using for that, you know, on them in person. And I like the idea that we can equip people with more tools for their self-care.
Mm-hmm. So increase patient empowerment and patient engagement in their own care.
Yes.
Yeah. Which leads to better outcomes, right? If you're more engaged in your own care, then you're more likely to have better outcomes, because you're more likely to be compliant and follow the plans and do the things that you need to do to maintain your health. So, and I realize we've lost the screen, so you can't see the questions, but so in what circumstances do the potential benefits that we've talked about outweigh the potential risks? And in what circumstances are the risks just too great? And that can be around, you know, in this particular circumstance with this particular disease state, or like you were talking about with like a new patient encounter. Is the risk of, you know, lower quality, is that risk too great? And so telehealth should not be used for that, or are there circumstances where it should? So what are your thoughts on that?
I think the benefits outweigh the risks for those that wouldn't go to the doctor at all if telehealth wasn't an option. So I feel like using telehealth is better than nothing in a sense. So I think that's one way the benefits outweigh the risks.
Any other thoughts on that?
In one of the readings that you sent to us, it was saying that if the patient needs like lab tests to be done, then telehealth can cause like delay in starting their like treatment and diagnostic.
Mm-hmm.
I have also had personally the opposite experience, which is that I couldn't get in to see my physician personally, but I could see her over telehealth, and that meant she was able to call in a lab, which helped me a lot. So both and for sure.
Yeah. So thinking about, cost and quality, and the risks that we have with telehealth that we talked about. So like things, you maybe can't see things very well. The patients may or maybe not be great at communicating what their needs are, technical glitches, missing diagnoses, all of those things. What are things that any stakeholder, so that would include providers, the patients, the payers, the vendors of the software or the hardware, anyone involved in the process, what are things that people can do to help mitigate those risks that could decrease quality or lead to poorer outcomes?
I think one way to mitigate some of those risks would be to use telemedicine kind of like as part of care instead of like its own separate form of care. Like it should be integrated with in-person visits and things. It shouldn't be like either you're an in-person patient and you see the doctor in person all the time, or you're a telemedicine patient, but it should be kind of like a mixture of both.
Yeah, Arden, I agree with what you just said too.
Are there things that the patients could do, for example, or the Medicare, Medicaid, the EHR vendors, the Zoom, anyone like that? Are there things that they can do to help mitigate some of those risks?
I guess vendors could probably make sure that that their software or whatever performs correctly and has less glitches. That way, like patients don't mind actually doing the telehealth visit because they're not sitting there frustrated. They're like, oh, okay, that was easy. That took, 10 minutes instead of, 30 minutes for me to drive there, sit there, whatever, stuff like that.
Mm-hmm. And that's something that we've seen recently. I recently talked to a provider who said, with COVID, we ramped up all our telehealth, and now we're pulling it back because patients had these negative experiences with the calls dropping and, all of the Zoom issues that I've had today where it keeps dropping and all of those things, and they don't want to use it anymore. And so they're pulling back because of that. So let's see if I can get. So things that we can do to, reduce the risk of lower quality and outcomes. How do those impact cost? And then should we even consider cost when we're determining what's our risk tolerance related to the quality and the outcome? When you're determining if, yes, there's a potential for there to be a decreased quality in one way or another, but, as with anything, there's a risk tolerance, right, of what's the likelihood of it happening, and are we willing to do it anyway? Should cost be considered when you're making those determinations, and how is cost impacting looking at quality? So for example, if the vendor, the software vendor takes measures to make sure that their software is more stable, how does that impact cost in the long run for the provider, for the patient, for the payer?
Sorry, I'm kind of going back to the last question, but also this one, because I just kind of thought about it, is one way to help kind of mitigate those risks also is kind of to do kind of like they're moving towards, we're not there yet, but we're moving towards kind of our system being quality based. So like paying for outcomes and things rather than just the services performed. And I think that helps mitigate some risk in telehealth, is that just like in-person visits, you pay for the quality of this are the outcomes that people are experiencing. And so I guess then it kind of becomes tricky, because if you have better outcomes, I feel like for the most part in a lot of situations that helps to reduce costs, because if you're catching things and you're helping people to manage conditions, then it's going to cost less in the long run. But I mean, I do think that, while the costs of those things shouldn't be like the most important factor, that you do have to kind of think about the cost and whether that cost is gonna, whether the quality and the cost are kind of lining up. Because if you have something that's, really low cost but really low quality, you don't want that either. So.
Yeah, I don't think any of us want the McDonald's of healthcare, right? Where it's fast and it's cheap. So we'll shift on over to access, talking about access. So, and you guys kind of touched on this a little bit, but in what ways and in what circumstances can telemedicine increase access to care? So we talked about, like, if you don't have transportation, that may, if you normally can't get to the doctor, that may be increases your access now that you do telehealth. Any other thoughts on access to care?
Maybe if some sort of pandemic happens.
Maybe.
I was surprised from reading the documents how before, like, telehealth wasn't approved to be used in people's homes, which I thought was really surprising, because I feel like it's a really good opportunity to get a real glimpse into people's home life and to be able to help in the ways that you can with how their home life is impacting their health. And it might just be something really simple, like there's like an example of, like, I heard a story. There was like these like newborns that were on oxygen and they weren't like improving as well as they wanted, but it was because like grandma would smoke next to the open oxygen tank. So it's like just simple things, like recognizing things that are happening in people's homes. Like that is something that can impact people's health, and being able to see it in real time, like on a screen in telemedicine, I think that increases access and also quality at the same time.
Yeah, that's another thing I've heard talking to providers who do telemedicine, is that during the pandemic, they love being able to do it in the patient's home because of that exact reason. They can walk me around your house, show me your home environment, show me what it looks like. And then they can see also, even, they can get a tour of the house and kind of see what the living situation is, and kind of have a better understanding of those social determinants. And they can see, okay, you have asthma and I saw 3 cats run across the street. Maybe, it's things like that. Or you have, well, I understand why you have, you stress in your life, because I've heard kids screaming the whole time we've been on the phone, things like that. So you can get a better understanding of those social determinants. But I think so. We know there's access issues in general, right, in healthcare, and so there's issues with access to primary care. There's issues with access to specialty care, all of those sorts of things. So, how can telehealth help with those access issues that already exist?
So maybe this goes back to transportation and time, but I know, speaking from my personal experience, because of the way that my insurance has worked in the past, um, I can't just like go to, I don't know, the dermatologist. I need to go to my normal physician, and then they need to write me a referral to go to my dermatologist. But then oftentimes things get lost in translation, and I show up to the dermatologist and they're like, oh, okay, we can't take you because you need a referral. And I'm like, well, I got the referral. They're like, no, you need to go back and you need to go get another referral. And it ends up being this complete hassle where I end up just not going to the dermatologist. And maybe I'll go once every 3 years because it just doesn't seem like I want to go through all of the whole process. So I think with everything being at people's fingertips, it would streamline that process, and it would make people encourage people to go to the doctor more.
Mm-hmm. And from the provider side, earlier someone mentioned, it decreases travel for the physician, right? And so maybe they can see more patients. Maybe they can be more efficient. They can see more patients. So more patients have access now. Maybe the waiting lists are shorter, those sorts of things. So those are all different ways that it can increase access to care. And we also talked about, patients being more comfortable, so in some cases doing telemedicine because they don't want to drive. And, one thing that, being from a very small town, I can attest that people know what your car looks like, right? So I may not want to drive and park at the STD clinic or at the psychiatrist's office or wherever, because when people drive by, well, they know what my car looks like because there's only about 30 people that live in this town, and I don't want people to see me there. And so I'm not going to access the care that I really need because of stigma that exists. And so this can, if I can do it from home, if I can do it in privacy, I may be more likely to access care. So in what ways and in what circumstances does telemedicine not increase access to care? And this is not the way that we're going to, fix the access issue. And then are there any ways in which it might further limit access to care?
I think one of the ways is, again, just thinking back to homelessness, or perhaps with people who don't have ready access to maybe a phone or a computer, to have a lot of care transferred to telemedicine and that be the primary means of care. It might not really work for people who don't have internet access or computer access.
I feel like if, and this is kind of projecting into the future, if there were a lot of technologies to go with telemedicine in terms of like tools for, getting vitals and sending them to the doctor from your home or whatever. There might be access to like talking on video chat with a doctor that was more equal, but then the higher quality care of like expensive tools might go only to people that have the money to buy them.
And just to kind of add on to what Harmony said, another population would be like older people who are not comfortable with technology. They, it wouldn't increase access to care because they probably wouldn't want to use it.
Mm-hmm. I thought I saw another person unmute, so I'm just going to give a couple more seconds in case you still want to make a comment. So in what circumstances would telemedicine increase access for some, but limit access for others? So a good example is, I'm going to try to find your name because it's not written. It's your email address, Nora. She mentioned that, in cases where we have a lot of, let's say, at-home monitoring, well, then you kind of create a disparity potentially, because if you have this really great equipment, but you have to have the means to be able to purchase it, then it's increasing access for those patients, and it may be limiting access for others. So what are some other potential circumstances, can you think of any, where it may increase access for some, limit access for others, and then in those circumstances, should we do it anyway, or should those things be, should we not utilize telehealth that way?
It makes me think specifically about the at-home hospitalization idea. That was, keeping folks at home with like all of these tools and care, like pretty intensive care. And that helped prevent, nosocomial infections or, hospital-based infections, and reduced the amount of time that they were in the hospital. And that just seems like a thing that if anybody has the means to do it, like, please do. I wouldn't ever want to restrict that to any, just because it's an unequal access.
Again, kind of from a dental perspective, I've noticed a lot of the dentists who I follow on like Instagram or have on LinkedIn, they've been doing a lot of smile consults over the computer with pictures and photos and things. So those are for things like veneers, like elective treatments that aren't necessary. So it would increase their access, but someone who has an infection who really needs the access, it wouldn't really help them as much because they need to, go in and be seen in person.
Yeah, and then potentially that provider who's doing all of these elective procedures, they now don't have any room for the people who have more medically necessary procedures, right? And so you're increasing access for some and decreasing access for others, and potentially creating maybe a moral gray area there, right?
Yeah, exactly.
So that kind of leads us into, and this didn't go correctly, but into the equity questions, right? And we've touched on that kind of all throughout. And I think a lot of you, what you're looking at in your scholars program is different ways that we have inequity in society, and I think we're all very aware of that. There's a lot of discussion about that right now, just, across the country about the inequities that exist in our societies and our structures, in kind of the way that things are built. And we certainly know that it exists in healthcare. And so in what ways and in what circumstances can telehealth help to overcome inequities that exist? Or even if it doesn't overcome them, in what ways does it highlight that these things exist and need to be addressed? So we talked about patients who don't have access to transportation, right? And so telehealth can help to overcome that lack of access to transportation, which is a social inequity that not everybody has access to vehicles or to public transport or to whatever it might be. Any other kind of inequities? Yes.
Yeah, so another common one would be, or easy one would be internet access. I know we live in America, so moderately developed country or pretty developed country. So everyone kind of has some sort of internet access, but a lot of places, especially rural places in Mid-East and even like around Louisiana and other not as developed states compared to like the more developed states, there are places, pockets of spaces that don't have as accessible internet compared to the more developed areas. And that kind of can be highlighted with if there was telehealth if it was more prevalent and patients weren't being able to be seen because of their lack of fast internet or whatnot, that could highlight the inequality there.
Mm-hmm.
You can also overcome the inequity for those that live in medically underserved areas. So just general access to everyone. Well, not to everyone, of course, but just for those that are in medically underserved areas, they have another option.
Mm-hmm.
One problem that I was reading about is how primary care and general surgeons and these like very specific kinds of doctors can get the rural grants to be working in rural places, but endocrinologists or cardiologists can't. And so, for example, there's like a really big problem with people with diabetes losing legs because it's general surgeons that are in those local hospitals rather than like cardiologists that could do vascular surgery. And so you get these pockets of rural areas that just have like a lot of people who have lost legs. And I feel like more than anything else, the idea of getting access to consultations with specialists is a really important way of overcoming inequities in healthcare.
Yeah, that's a huge one. And the internet access that you mentioned, that actually has been something during COVID that has come up and has been talked about. And CMS, in one of their recent publications, they issued a couple of, they issued several rule changes, but they issued two big documents of rule changes. And in one of them, they actually wrote in the document, I'm paraphrasing obviously, but basically they said, we know that providers are already using audio only, and instead of the audio video, because before, Medicare wouldn't reimburse a phone visit. You had to have a video and audio for the visit to be reimbursable for telehealth. And they put in the rule, they said, look, we know during COVID you're doing it because the patients don't have computers, they don't have smartphones, they have, some of your patients have flip phones with prepaid minutes. And so you're already doing care via audio only. And so during COVID, we're going to reimburse you for that. And so that's a really good example of how the use of telemedicine is highlighting that these inequities exist and that not everybody has access to internet and smartphones and even good phone connection because they're using, prepaid phones. And so it's highlighting those inequities. And the payers are trying to come to the table and help address that, at least during COVID.
One of the things that I learned, one of the disparities that I learned about recently was digital literacy. Just even if you have a computer and you have internet, you might not really know how to use it. And that's not something I really considered before this pandemic. So that was something that I learned.
Yeah, and that actually leads really perfectly in the next question of what circumstances does it not address issues of inequity or exacerbate. And so in those cases where you have people who are not very literate, technology literate, or have poor health literacy, this may not be a good option for them, right? If they can't use it and they're not comfortable, even if they do have it. Right? Are there other circumstances you can think of where telemedicine isn't really helping with inequity, exacerbating them?
I think it could help exacerbate inequities in the sense that it runs the risk that those that would have the time and the ability to be able to go to the doctor's office might use it more because it's more convenient, and then those that really have like trouble with access and with being able to get to the doctor's office are kind of secondary and being able to use it in the first place. So then you run the risk of it's just exacerbating the problems that people already have with access, but now it's just there's a limited amount of space for telemedicine, and you have people that could otherwise do other alternative forms of medicine that use it more for convenience than out of necessity.
Mm-hmm. So I see we're getting short on time, so we're going to jump ahead a little bit. So how does telemedicine's impact on access affect health equity? So we've kind of touched on that a little bit. Does anyone have any thoughts or comments they want to make on that? And then we talked about this too. How is reach of telemedicine impacted by disparity? So we talked about lack of internet access. That's a disparity that already exists, and it's inhibiting the reach of telemedicine. I can't reach patients because they don't have internet.
I feel like telemedicine. Oh, sorry. Go ahead.
No, go ahead. I was talking to myself. I was reading that.
I was just thinking that it's kind of like one of those things that as it becomes more accessible, it's going to kind of mirror society in the sense that the inequities that we see now, they're just going to kind of be mirrored in telemedicine unless we like really take active steps to kind of make it more accessible to people that traditionally don't have access to medicine. But if we just blanketly make telemedicine more accessible, then it's just going to mirror the disparities we see in healthcare already.
Yeah, and what just Arden said and previously kind of wanted to second that. One of the, just something interesting that I was thinking of while she was saying that, something that I was exposed to recently was that there's been like multiple studies that shows that doctors, or specifically primary care providers, they tend to spend more time seeing patients who are of certain social class, usually tends to be higher social class, compared to lower social class who they spend less time seeing. So these kind of discrepancies, I would be very interesting how they would manifest when healthcare is being delivered via telemedicine. As Arden said, it could manifest in the sense some people would be able to go see the doctor, which would be better. Like, I guess maybe quality of healthcare would be different. Might be better compared to people who are just talking to them on the phone, talking to the provider on the phone. So it's interesting.
Yeah, and that's an excellent point of, telemedicine is a tool, right? It's not a service, it's a tool that we're using. And so if it's not implemented and utilized in a very, very thoughtful way and very purposeful way, it's going to do exactly what you said. It's going to mirror all the inequities and all the issues we already have in healthcare, right? We're going to still have lack of access. It's just going to be virtual access versus, in-person access. And we'll still have these inequities and all of these things. And, we may have providers who are doing these elective things and not the really medically necessary things. And so we're mirroring all these issues we already see in in-person care and telemedicine. So building on that, what are ways that we can, as stakeholders, patients, providers, vendors, payers, what are the steps we can take to really critically think about how do we make access equitable via telehealth?
I think a big thing that stands out for me is kind of pushing for it to be something that's more universally covered by a wide range of insurances and Medicare and Medicaid, because I think part of the way that it becomes more accessible to people is if everyone is able to afford it. And then, there's the whole problem of being able to access it. But if you can't even afford to use it, then there's definitely, it doesn't even matter if you have access to it or not.
I think if we kind of think about like a rural population, so they might have some kind of healthcare provider there, but someone may need to speak to, like someone said it earlier, like a cardiologist or a specialist. They could maybe have, an iPad or a computer at their office where they could, come to their office, but have a visit with a specialist who's, maybe in the bigger city or something like that.
Mm-hmm. Yeah, and something that, we talk about, we think about as, in the world that I work, I guess, in trying to be creative, especially when you get grant dollars and things like that, of how do you address equitable access is, getting creative with providing access to patients who don't have it, giving them mobile hotspots, giving them tablets to have access, giving them education on technology, things like that. So there's a lot of ways you can get really creative, especially, and there are people who've partnered with payers, with some of the Medicare managed care plans, to will you pay to provide these patients with that they otherwise wouldn't have access to, things like that. So there's a lot of ways that, out in the world you can get creative and find the people with money and help to, distribute that access more equitably. So based on the discussion, I'm going to pull up all the questions and we can kind of just talk about, we just have a couple minutes left, to think about in what circumstances does telehealth have the potential to do the most good and should absolutely be? Are there circumstances where it has very little potential and should not be used? And then what are some factors that would impact those decisions about when you should and shouldn't use telehealth that we didn't talk about today?
For the time that it should be used can be when there is an infectious disease, like any infectious disease. I think that would be better to use telehealth, or any pandemic.
Mm-hmm.
And I think an area where it's done a lot of good, and I don't know for sure, but I think it's been happening for a long time, is just mental health, doing that over telemedicine.
Yes, that's correct. That's the most common use of telehealth. Up until COVID, and now the use has expanded quite a lot. But prior to COVID, it was the majority of telemedicine was used for mental health because it's relatively easy to do. You don't need a lot of equipment and all of that sort of thing. So in your future practice, your work, and all the different areas that you guys are going into, are there ways and circumstances that you would want to utilize telemedicine in one form or another?
I think one way that it could be really useful is for somebody that might have a chronic condition that, you know, gets regular checkups, but there's not much change from like from like month to month, or maybe even from year to year. Like if somebody has, for example, like if you've diagnosed somebody with diabetes and they're managing it well, and they just need like, you know, you're just gonna check on them and see like any changes and that kind of thing. Like if it's something that they're noticing that's different, but if it's just kind of like how is it good? Is there any changes? No, you know, that's useful, that it cuts down on transportation, and also like, you know, it makes the visit more efficient if it's just kind of like a general wellness check maybe, rather than something that like is kind of acute that showed up, that, you know, is something that maybe is something very drastically different from what was happening with the patient before.
I thought your point about not wanting your car parked at the STD clinic, as an example, is something that I would really emphasize, where if I were treating somebody for something that's highly stigmatized, then I would definitely want to offer telemedicine as a way to be discreet.
Also, I know in audiology that there are a lot of like snowbird customers and people who, you know, travel a lot. So just having the convenience of being able to send a message to your audiologist for hearing, like to adjust hearing aids, or, you know, if they're having like a minor troubleshooting issue, I know that makes it more convenient for the patients instead of trying to make an appointment, and it kind of makes it more convenient for the audiologist too, because they don't have to try and, you know, squeeze them in between, you know, a packed schedule.
So I don't know if there's a ton of ways to use telemedicine in dentistry, but one way that I was thinking might be good is if someone is really anxious or really scared to go to the dentist, which a lot of people are, if you had, you know, a little talk over, you know, a video chat with them and kind of, you know, looked at least at what you could see, kind of took a look, it might make them more comfortable and make them more likely to come in.
Yeah, I think that's great. There's actually been some increased interest and discussion around teledentistry, and Medicaid just recently during COVID has allowed for more reimbursement for that, particularly in the FQHCs, the federally qualified health centers that have dentistry in them, and so they have some codes specifically for teledentistry that they can get reimbursed for, kind of check-ins with the dentist to do an assessment, to say, a very basic, like, that, oh, it looks like it's fine, it'll go away, your pain will go away, or like, oh no, I think, you need to come in, we might need to pull that, whatever it might be. And so there's a lot of increased discussion about what you can do with teledentistry. And so hopefully there will be more talk about looking into that. And I think that's a great idea to have a first visit to reduce anxiety. Speaking from personal experience, my mother didn't take me to the dentist as a child because she had such anxiety about the dentist, she didn't even want to bring me in there, go herself. So I was relatively old before I started going to the dentist. So that is definitely a legitimate use. So we are a little bit over time, and I apologize. I did want to give some time. Are there additional questions? Any final comments? Anybody who didn't get? I think I've seen everyone spoke at least once or twice. But if there's a question or a comment you weren't able to get in and you'd like to get it in, please feel free. I would love to hear any questions or comments you guys have.
All right, guys. Well, if no one has any closing thoughts, then I will just thank you very much and thank Danae the most for giving us such an interesting and enlightening presentation on, thank you, on telehealth. And you guys will be getting an evaluation soon. It may actually have already posted to your Google Classroom account. And there's a scheduling feature that I love. And Danae, I will share the results of their feedback with you in aggregate form. So thank you everyone very much.
Yes, thank you. Please do share those with me. And please be honest with your feedback. If you hated this format and you did not like doing it this way, I am definitely open to that feedback, and will not do it this way in the future with anyone. Or if you really liked it, please let me know that too, and I can utilize this format going forward. So I do really appreciate your honest feedback, and like you said, it'll be aggregate, so I won't know that it's you. And then she can provide you with my contact information. I'll share my screen again really quickly. So you can see that's my email address. So if you have any questions at all related to telehealth or anything else that you think I might happen to know, feel free to email me or reach out to me. I'll be happy to answer any questions.
Thank you.
Thank
you.
Thank you.
Bye. Thank you.
Bye.
Thank you.
Bye.
So wait, I actually have one last thought.
Sure.
I knew there was going to be one.
Sorry.
Hanging on.
Okay, so it's not, I mean, I guess it kind of is telemedicine, but not exactly. I'm thinking in more terms of research and how there's a need for more diversity in sample, in research samples. Do you feel like telemedicine could help increase diversity in research? Because I feel like a lot of the health data we have is not representative of the population. And I feel like over time that could help with inequities, but it wouldn't be anything immediate.
Yeah, that's a very good question. So, I mean, I'm thinking my wheels are turning. So I'm thinking we're actually I'm really trying to get us to support a telemedicine research project here in the near future, because I would really love for us to do a statewide one. And so, thinking of that, like, depending on how you're doing a research project, right? Like, how do you capture your population? And so you do miss potentially population. And so particularly in Louisiana, I think we're pretty lucky in that we've had Medicaid expansion, and our Medicaid reimburses pretty well for telehealth. And so you do see, and I don't know that much about research, but I would imagine that the patients who would be on Medicaid are also maybe likely to be patients that are not represented in research. And so if they have coverage via telehealth, then you can get the data for those patients, right, if you're studying telehealth. So in that way, I think, yes, you could potentially increase the access for patients who can't get into the clinic to participate in research and trials or whatever it might be. If you're increasing access for those patients, then you're more likely to be able to include them in a research study. Does that make sense? Does that answer your question?
No, that definitely makes sense. That's kind of that was kind of my thought process too. Thank you.
Yeah, no problem.
I love how it has the little thing that pops up to let you know you're muted when it like senses that you it's like, hey, done.
Yeah.
Well, thank you, Val. That was a really thoughtful question, I think. And so I appreciate it. And thank you, Danae.
Yeah, thank you.
All right. Talk to y'all later. Everyone have a good dinner.
All right, you too. Bye-bye.
All right, bye.